Hi, I am Dr. Rizwan. I am an internist, and today I will make the causes behind the renal failure clear for those who find it difficult. So keep watching. By renal failure, what I mean is it may be either acute kidney injury or chronic kidney disease, or sometimes it can be acute on chronic kidney disease. But today my focus will be on acute kidney injury. So what is acute kidney injury? I already have taken a prequel of this class about the basic concepts of acute kidney injury. For those who are interested, the links are given below, so you can watch that lecture first and come back to this, and this will really help you. So for the first timers, the acute kidney injury is a medical emergency in which there is a renal insufficiency developing over a short period of time, and hence the name acute. And what it causes to build up metabolic waste products inside our body, which can put a patient's life in danger. So it is very important for a physician to know what can cause these acute kidney injuries and how to differentiate these causes, because the treatment modalities really depends on what is producing the acute kidney injury, and as it has substantial mortality rate. So if we fail to delineate the cause, in that case it will hamper our management of the patient. So traditionally, the causes of acute kidney injury is categorized into three types, that is prerenal, renal and post-renal. If I take out the kidney of a prerenal acute kidney injury patient or post-renal acute kidney injury patient, and I transplant this kidney onto another person, it will work just fine because that kidney is not diseased. Only in the renal cause or the intrinsic causes, the kidney has a problem of itself. So prerenal causes, what causes the prerenal acute kidney injury? One thing to remember before digging deep into the prerenal causes is that all the prerenal causes produces renal insult by renal hypoperfusion. So as we know that kidney is a very vascular structure and it gets 20% of the total cardiac output. So in any condition which causes the renal perfusion to decrease may end up into producing kidney injuries. So why there should be renal hypoperfusion? The renal hypoperfusion can be due to low volume, low tension or low output. By low volume I mean anything that causes hypovolemia. So it can be loss of fluid through GI tract, through renal tract, or through skin, or blood, simply blood loss. So anything which causes hypovolemia will cause this low volume condition. The next is low tension. So what is low tension here? The low tension situation is something which is not associated with hypovolemia, but it has a decreased effective circulatory volume. Why? Either because vasodilatation or because third spacing of fluid or hypoalbuminemia, or a combination of these factors. So a classical example of this will be sepsis or chronic liver disease. So in case of hypovolemia, there is hypovolemia as well as hypotension. But in case of low tension, there is hypotension without hypovolemia. The third category of the prerenal acute kidney injury is low output. By low output, I mean low cardiac output. So if there is heart failure or cardiogenic shock or the pericardial disease which limits the heart's ability to be relaxed, like pericardial cardiac tamponade, they all can cause renal hypoperfusion. So having said that, one more category should be remembered that cannot be rhymed into these categories of low volume, low tension and low output, is the disruption of renal autoregulation. So some organs of our body has their intrinsic capability to maintain their own perfusion, like brain, like kidneys. So as we know, the kidney is very much capable of maintaining its perfusion in the face of systemic disruption. This is called renal autoregulation. And one of the key factors by which the kidney maintains this autoregulation is by the constriction and the relaxation of afferent and the efferent arteriole. So anything which produces the difficulties with the relaxation and constriction of afferent and efferent arterioles may cause the failure of this renal autoregulation mechanism, like use of NSAIDs or use of ACE inhibitors. As we know that the NSAIDs blocks the production of the prostaglandin. So if we take NSAID, sometimes what can happen, it can cause constriction of the afferent arteriole. So the afferent arteriole will let less amount of blood to pour into the glomerulus, and that can cause renal hyperperfusion. And the use of ACE inhibitors, normally angiotensin II causes constriction of the efferent arteriole. So when we use ACE inhibitors, this mechanism is blocked, so the efferent arteriole can be dilated. It can reduce the intraglomerular pressure. Thus, it can reduce the GFR, or in other words, it can produce AKI. So to wrap up things, in the prerenal categories of the etiologies, we get the low volume or hypovolemia, we get the low tension, in which there is sepsis and CLD, which are not associated with hypovolemia but are associated with hypotension, and we get low cardiac output scenarios. And last but not the least, we get the drug mechanisms like NSAIDs and ACE inhibitors. So if I want to differentiate between these etiologies, first, the history of drug is very much straightforward. So if it is due to the drug, we can just be confirmed from the history of the patient. In case of other three categories, the low volume, low tension and the low output, there are many points to differentiate them at the bedside, but the fastest way to differentiate between these are the JVP and the peripheral temperature. So regarding the jugular venous pulse or jugular venous pressure, if it is raised, it indicates towards the cardiac causes. So if the patient is suffering from heart failure, the JVP will be raised, but in other two cases, the JVP will be low. And in case of the low tension scenarios, that is sepsis or chronic liver disease, the temperature of the periphery will be warm, but in other two categories, the temperature of the periphery will be cold. So this is how we can differentiate clinically what is causing this prerenal AKI. Now the next step, renal or intrinsic causes of AKI. So as we have said, the renal or intrinsic causes of AKI means the kidney is diseased itself. So what can go wrong with the kidney? If we look at the anatomical structure of the kidney, there are glomeruli, tubules, there are interstitial spaces and the vessels which supplies these structures. So in the glomeruli, the common causes which can produce acute kidney injury is glomerulonephritis. In the tubule, the classical example is acute tubular necrosis or ATN, and in the interstitium, the allergic interstitial nephritis is the commonest cause. It is also known as acute interstitial nephritis. Regarding the vascular causes, the easy to remember causes are vasculitis, accelerated hypertension or malignant hypertension, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome. So this is how we can remember the anatomy and can correlate with the anatomy the causes of intrinsic or renal AKI. So one thing about the ATN is any causes that we have just discussed about the prerenal AKI can ultimately produce ATN if they are present for a longer period of time. I will say it again. So in case of prerenal AKI, what was our key pathology? Our key pathology was hypoperfusion. So the kidney is getting less amount of blood that it deserves. So if the kidney is getting less amount of blood than normal, and this persists for a longer period of time, then it can produce an ischemic injury to the tubule, and this is what we get in acute tubular necrosis. Ischemia followed by necrosis. In majority of the cases, the acute tubular necrosis is due to the prolonged presence of the prerenal causes, that is the renal hyperperfusion. So in about 30% of the cases, the acute tubular necrosis are due to toxins. They are not due to renal hyperperfusion, but they are due to toxins. Now, these toxins can be exogenous, that is from the outer sources, or it can be from endogenous. So, example of exogenous toxin can be nephrotoxic radiographic contrast media. An example of the intrinsic toxin can be hemoglobin in case of hemoglobinuria, myoglobin in case of rhabdomyolysis, or immunoglobulin like in multiple myeloma. So, ischemia or toxin can produce acute tubular necrosis. Now, there may be a confusion between the prerenal AKI, which is associated with hypoperfusion, and the renal AKI, which is due to ATN or acute tubular necrosis. Why? Because they are very closely related to each other. You know, the hyperperfusion of the kidney, if they are present for a shorter period of time, they can cause prerenal AKI. If they are present for a longer period of time, they can be presented with renal AKI by producing acute tubular necrosis. So how do we differentiate between this prerenal AKI and acute tubular necrosis? Once again, it is not that tough. There are a lot of differentiating points, but my favorite top picks to differentiate them very fast and easy way are 3. But before I tell you that, we have to remember one basic thing about acute tubular necrosis, and that is in acute tubular necrosis, the tubules of the kidneys are damaged. So their basic functioning like tubular reabsorption and tubular secretion are not going well. So we have to remember this, that in acute tubular necrosis, the tubes are not effectively preserving water and salt. So it is letting the water and salt to be washed out in the urine. If you can remember that, differentiation between acute tubular necrosis and the prerenal AKI should be easy. In prerenal AKI, as the kidney is hypoperfused, but the tubules are still normally working, so the kidney will try its best to preserve water and electrolytes. So you will pee really concentrated amount of urine, and the urinary osmolality will be high, and that urine will contain less amount of sodium, because if you can remember, kidney is hypoperfused, so kidney is trying to preserve some water and salt, so the urinary sodium will be less and fractional excretion of sodium will be less than 1%. The exact opposite will be seen in case of acute tubular necrosis, because the tube are damaged, so it cannot preserve sufficient amount of water and salt. So the urine that you are passing in acute tubular necrosis will be a diluted one. So the urinary osmolality will be less than 350 milliosmol per kilo, and the urinary sodium concentration will be more than 20, which is less, by the way, in case of prerenal AKI, and the fractional excretion of sodium will be more than 1%, because it cannot preserve sodium. After finishing all these renal causes, if you are thinking that it is too much for you, I have a last tip, that to differentiate between the glomerular cause, the tubular cause, and the interstitial cause, a simple test, urine examination under the microscope, can be of great value. How is that? Because if you find cast, which is a very characteristic finding in case of renal AKI, that cast can lead you to the exact etiologies of the renal AKI. How? If I get RBC cast, it may indicate glomerulonephritis. In case of acute tubular necrosis, we get pigmented granular cast. And in case of allergic interstitial nephritis, we can get WBC cast. If I want to tell you something about the allergic interstitial nephritis, so allergic interstitial nephritis, as the name suggests, it is usually due to ADR, adverse drug reaction, and the common example would be antibiotics like penicillin, cephalosporin, or sulfur-containing drugs, or even anti-gout medication allopurinol. And sometimes, to a lesser extent, they are associated with bacterial, viral, or fungal infections. And clinically, the allergic interstitial nephritis are associated with fever, rash, and eosinophilia. The most straightforward etiology of the acute kidney injury are the post-renal cause, obstruction of the urinary drainage, So this obstruction can be anywhere from the renal calyces to the urethra. So it can be due to bladder neck obstruction or stricture of the urethra or bilateral ureteric obstruction or unilateral ureteric obstruction in a patient who has only one kidney. The common causes though is the benign enlargement of the prostate. So the cause that we get clinically is the benign enlargement of the prostate. So how do we get the patients with the post-renal causes of AKI? As I have said, it is the most straightforward etiology among all. These patients of post-renal AKI, they present with a distended bladder, and as soon as we catheterize the patient, gush of urine comes out, and in renal imaging what we get a distended bladder, and we get sometimes hydroureter and hydronephrosis. All this points towards an obstructive etiology. So that essentially wraps it up. Up until the next time, stay blessed. Thank you very much.